Hello, this is Dr. Casey Hill broadcasting from Baton Rouge to see if there are other survivors out there. My family has enough food for about 1 month, but only enough toilet paper for about 1 week. Please send help. Seriously, as if our current situation isn't weird enough having to give this presentation alone in a room. Hoping that you watch it alone in a room is really weird and depressing. So if you find it useful, please let Clara Cantro know so maybe she'll invite me back to speak in person sometime. I do really appreciate her giving me the opportunity to speak about some of what I do with runners and hopefully help you feel more comfortable treating runners as well. As I debated what to present on, I kept thinking about how much of the medical profession can be pretty dismissive of runners and doesn't really like dealing with their type A personalities and addiction to running. Hence a little tongue-in-cheek title of Dealing with Runners. And as I thought about the large number of runners who have come to me after months of therapy that is heavily focused on modalities and low-level exercise, but light on research-backed things that might actually help, the second tongue-in-cheek part of the title, Moving Beyond the Mat. So let's get going. Hopefully you find some useful information in here. I think these memes are a good example of why it can be challenging to deal with runners. As you know, they will do and say anything to rationalize their injury and why they need to keep training and keep racing. Maybe the most hard-headed runner I remember was a nurse practitioner who walked an entire marathon in a tall walking boot while being treated for an anterior tibial stress reaction. Luckily, she didn't end up needing a tibial nail, but at least we could make fun of them a little bit. So learning objectives for today: have a better understanding of running biomechanics and the mechanics associated with injury risk. Something a little bit weird about how I give presentations, I tend to not focus on single injuries or even body parts, as my approach to both lectures and gait analysis is really to focus more on the overall mechanics, as I find that usually works better than getting too hung up on a particular injury. Help you be better able to assess and correct these mechanical issues, feel more confident in treating runners and athletes as there's a lot of overlap. Understand some of the overlap in treating running injuries and back pain. Hopefully I remember to point those out. And have increased therapeutic exercise options so we can hopefully move beyond just doing clamshells. A little bit about me so you can understand why I'm kind of a weird doctor with a bit of a unique practice. I grew up in the big town of Delcombe, Louisiana, about 30 minutes south of Lafayette. I played football and track and cross country, but really sucked at cross country. Here I am starting the race exactly where I'd finish it, in the back of the pack. Had a lot of shin splint issues and didn't really get very good advice on that. Not to put all the blame on someone else, but certainly didn't help. Finished high school, went to LSU for undergrad, became more of an out-of-shape weekend warrior, still tried to run and hike and backpack on occasion, but developed some pretty bad knee pain. Saw a few docs and got an answer that kind of looked like this: not totally sure what's wrong with your knee. And then before finishing college, I also developed a new pain in my low back that felt exactly like how this looked, except it also went down my left leg. Once again, I didn't really get a lot of relief from the medical system, including my first exposure to physical therapy. So I took that back pain and knee pain and progressive deconditioning and started LSU med school in New Orleans. Now, during the time that I was in med school, I was dating a lovely girl who I'd eventually convinced to marry me, and that is Rochelle right here. Now, while I was in med school, Rochelle was in PT school. We'd get together to study, and I was kind of bored with microbiology and pathology, and found that the kinesiology and kinetics and human movement were much more interesting than what I was studying. I was wondering if maybe I should have gone to PT school. I was also the frequent guinea pig of the study group in their class, and they actually gave me better diagnosis and explanations of my problems than most of the doctors did. Thankfully, I discovered physical medicine and rehab before I finished med school, and they seemed to be a little more on the same page with PT. This led to moving up to Charlottesville, Virginia to do a residency in PM&R at University of Virginia. And we had a really huge focus on treating athletes and runners there. Leaving residency, I made I'll back up. So it was at UVA where I finally got an MRI. And if you're familiar with looking at MRIs, you can see I had pretty bad disc bulge at L5S1. Can't really tell where my S1 nerve should be. Here it is on the lateral view there. Pretty big disc bulge. I've certainly seen people get injections and surgery for less, but I had neither. Instead, I had really good PT and also some help from Pilates. Actually helped me quite a good bit. So started doing my own rehab and felt a lot better. Left residency, moved from Virginia, took a job in Florence, Alabama, treated runners, but mostly got stuck treating back pain and got really tired of Alabama fans. And so my wife and I decided to move back to Baton Rouge, and we've been back here for about 6 years now. Now, when Claire told me that it was a pain symposium, but they wanted to have a variety of topics, I was a little thrown off about the whole running medicine thing. But the more I thought about it, I realized there's actually a good bit of overlap between how I treat runners and how I treat folks with low back pain. I'm not sure I always spelled that out in the slides that are coming up. I'll try to point it out when I can. First few years back in Baton Rouge, I actually worked for Moro PT, but over the last year, I switched over and have been working with Ochsner Sports Medicine. Now back to UVA, one of my big mentors was Dr. Bob Wilder, who ran the Runners Clinic. First couple weeks I knew him since I was from Louisiana. He only spoke to me in Waterboy quotes, but he's a pretty smart guy who wrote the only 2 textbooks of running medicine. Here's the latest edition. Now, Dr. Wilder definitely had a diagnostic and kind of typical treatment approach with imaging, anti-inflammatories, rest, advice, that sort of thing, and he would send patients to good therapy. But if even that good therapy did not work and we tried all other options, usually the last option for a runner was to send them to this guy, Jay Deshari, Louisiana native, LSU PT grad, and he was up at UVA running the speed clinic at the time that I was there. He has since left that. He's moved over to Bend, Oregon, where he runs the Rep Biomechanics Lab. And of course, he's the author of Anatomy for Runners and Running Rewired. If you like working with runners, if you like some of what I talk about, these books are a must-have for you. They go into so much more detail about many of the things we're going to talk about. Now, as a guy who treats runners but has never been and probably never will be a great runner, I also really appreciate this quote that I got out of the Science of Running book. Poor hitters make the best hitting coaches. They don't try to make you like them because they sucked. The interesting thing about runners is that they always want to know if the person treating them is also a runner. So I at least try on occasion, but certainly have my struggles with it too. Then I love this second quote that actually got out of Anatomy for Runners, Jay's book. Much can be gained if the biomechanists and pathophysiologists come out the lab, the clinician pulls himself out of the clinic, and they all meet on the track. Which sort of reminds me of something Jay told me once, best piece of advice I ever got: read everyone and make up your own mind. I have a feeling that during this pain symposium, you're going to hear a lot about using a biopsychosocial model for treatment. We're really not going to dig too far into this, but I think we need to talk for a second about some of the psychology of running. So bad psychology, right? Another funny meme, when you say broken, does that mean I should or should not race this weekend? Now, if you're not really into runners and you don't want to treat them in the clinic, here's some runner repellent for you. Just tell them, just stop running. Why do you really need to run so much? Or tell them that they're crazy. Now, I might tell them they're crazy, but I've kind of built up the reputation and rapport that allows me to do that, I think. But the number of patients I get who are just frustrated because they don't feel like a doctor is taking them seriously, or the doctor gave them some advice like this. Just be understanding and understand that they want to run, and whenever possible, keep them running. Maybe they have to modify things, but if you can keep the runner doing what they want, they're going to love you for it and be more likely to follow up and send their friends to you. Now, there are a couple of hard stops out there. I pretty much never let anyone run with a stress fracture or stress reaction. Acute radiculopathy. This was something I was taught in residency. I'm not sure I've read this, but probably not a bad idea to not go pounding on acute radiculopathy. And of course, sometimes there can be medical issues. If we got some possible pulmonary or heart issues or coronavirus issues going on, we might not want to run with that either. And then I give them the return to run guidelines and put some of this on them. I probably should have made a slide of it, but here they are, basically, and this comes from Dr. Wilder. You don't have to be pain-free to run, but we want the pain to be very low, say 1, 2, 3 out of 10 on the pain scale. kind of tell them by the time they're saying ouch with each step, it's time to stop running. Then there's a little bit of a caveat to that. Think of like soft tissue issues or plantar fasciitis that maybe in the first few minutes of running, the pain is pretty bad, 5 or 6 out of 10, but they know it's going to warm up and be below 3 out of 10 soon. It's okay to push through that for a few minutes, but I'd say not more than 5 minutes. And then no running if they are limping or changing their gait. And then I've kind of added the fourth rule just to remind them about the 10% rule, that increasing their mileage no more than about 10% a week will usually help keep them out. Now, there is a little bit of research behind running psychology. Besides the physical benefit, a lot of people run for mental health benefits. It's been shown to lower anxiety, lower depression. It's actually just research out there that any types of exercise can treat anxiety and depression about as good as pharmaceuticals, at least for moderate anxiety and depression. Some people use it somewhat as a form of meditation, helps with stress relief, increases socializing, or at least it used to before the word social distancing came into our lexicon. And there's been a couple studies, showing that regular leisure time physical activity less likely to report symptoms of depression and anxiety, and regular exercise associated with lower neuroticism, anxiety, and depression, and also increased extroversion and sensation seeking. I remember something out of the book Born to Run, another great book, but probably shouldn't be taken as a scientific dogma though. But he mentions that every time America has a national crisis, there's another running boom. And I've actually already seen one story in the New York Times that people are turning to running, especially as gyms are closed. And we think it's safe to be running outside as long as you don't pass too close to anybody. So when this is all said and done, we might have a whole new crop of runners and probably a new crop of running injuries to deal with. And the other thing to know about running, besides the psychological benefits, is that there really is some withdrawal symptoms from running. Now, the only study I found came from 1988, but they showed that when consistent runners can no longer run, they really felt some of the same psychological problems that someone feels from drug withdrawal. So the good news is, though, is that you can be their dealer. You can help give them what they want, right? And so if you're aware of some running substitutions that their family doc or orthopod probably did not offer to them, you're going to look like a hero. And I kind of put this list in order from my most favorite to probably least favorite, and it really has a lot to do with kind of the neuromuscular planning of running. That pool running is probably the closest thing to regular running. I'm a little less familiar with Alter-G, but I'm aware there have been some studies showing it can be safe with stress fractures. I would certainly recommend you familiarize yourself with that before recommending it. Elliptical looks a little less like running, and then cycling is even less, but at least it keeps up cardio. I'm only going to talk about pool running, and that's partly because my mentor, Dr. Wilder, did a lot of research on it. A lot of this was published in the early 90s, but you can actually maintain pretty good fitness for about 6 weeks. Before you see a big difference between land-based and pool-based training. I think it's okay for a lot of running injuries. We especially use it with stress fractures. However, I think there might actually be almost increased force through the hip. And so femoral neck and in anything around the hip, and sometimes even femur, I'm real careful to put them in a pool. But even with pool running or any of these substitutions, we want to kind of keep that return to run, return to activity model in mind. If the pain's worse than 3 out of 10, even if they think it's a safe exercise, they probably shouldn't be doing it. Now, a lot of people tell me they're familiar with pool running, and then I find out they're trying to run across the shallow end of the pool. That's not really it. Real pool running, they need to be in the deep end, feet not touching the bottom. They should be wearing an aqua jogging belt so that they're not trying to swim or tread water. The belt's keeping their head above water. And then basically they're trying to really reproduce the movement of their movement of running with arm swing and keeping their cadence up. And you actually move forward slowly. So if they have a lap pool, they can go back and forth. If they're doing it in the backyard, they might want to tie off to the side of the pool. There's a lot of good information on this. I have it saved. I joke about a spam email I send people. So I got a huge chain mail that I think I've sent to over 100 folks now that has a link to a good Runners Connect article. Runners Connect in general has a lot of research-based information. It's a good resource. But moving beyond the psychology, I spend most of my time really in clinic looking at biomechanics. I'm not sure it's a real financial disclosure, but I have had a strength and education class for runners going on about 5 years now. It gives me a group of guinea pigs about 3 times a year to practice these exercise progressions and drills on. People don't really get an individualized gait analysis, but they get a pretty big taste of practically everything they can do to improve their running. And it's been a good lab. I've generally hosted it out of personal training studios, but also some therapy gyms like Delta Physical Therapy. Here we are in New Orleans, and my teachers at all these locations have included physical therapists because I want people with a good movement basis and people who aren't scared to coach and cue and touch patients and make sure they're not just doing an exercise but really doing it well. And it's been a good learning classroom for me. Now, for those who don't want a 12-week class or want to know specifically what they're doing in their running, I have done gait analysis for 6 years now. With gait analysis, not just watching them run, but I'm getting a detailed history, of course, looking at their gait. The gait kind of tells you what they do when they're running, but you need to combine that with a physical exam to understand why they're doing it and how that might relate to injury. Now, one of the ultimate goals of gait analysis is to change their movement patterns. But rather than just say, hey, move differently, we got to make sure they have the right ingredients in place first. They need to have the right range of motion, no more, no less. So we look at flexibility. This would be a little bit excessive. Most runners complain about their hamstrings, but they really only need about 70 degrees of hip flexion. Sometimes it's not flexibility, but a mobility issue, right? All you manual therapists know that. Of course, I like to teach my runners how to take care of themselves with foam rolling or the stick or lacrosse balls or the manual therapy when they need it. Runners need more strength than most of them realize, and they need to be stable, be able to stay upright on one leg. Of course, if I find out any of you have my runners doing this in your PT gym, I'm probably not going to refer you to many more, but this guy is stable for whatever the purpose of this is. And they need to have good motor planning, which is kind of the recipe. They got to be able to take all these ingredients and tie it together for good running. And this is a guy who might be a terrible runner, but it seems like pretty good motor planning if he can pull that off. And more and more, I try to start with the goal and kind of work backwards from there. Something I've learned a lot from Jay. Obviously, as a clinician, oh man, slide credit to Jay on this one. As a clinician, our goal is usually to fix injuries, right? That's usually why runners are coming to us. But when a runner is not injured, their primary focus is usually on improving performance. But this can really be a false dichotomy. Why can't we have the best of both worlds? If we're really doing good therapy, I think that we're minimizing injury and usually improving performance at the same time. And this is really the holy grail of running medicine, and this is what will keep runners coming back to you and sending. So getting into gait analysis, one of the things that Jay taught me first was to start with the big picture. Don't get too hung up on looking at the feet or thinking about pronation, but start really kind of from the head down and look and see what jumps out at you. One of the first big things I look for is posture, and we have 3 examples here of very different types of posture. And these are all from real runners I've worked with in clinic. We'll talk a little more about the first guy and the last guy. I'm not a little bit about the lady in the middle as well. This would be more fun if we were in a conference and I can ask what you think about each one, but I'll give you a second to kind of look at them and get your own thoughts. So to address posture and what's supposed to be an evidence-based lecture, right? So I hear therapists talk about posture. I talk about posture. My wife fusses at me about my posture, and she's a PT, remember. But the truth is, we've had more and more research saying that, hey, we can't really show a strong support for posture and pain. We don't know that necessarily causes or reinforces back pain. It's really only if someone has to do a lot of work in a posture that they're not used to, do we see a little temporary flare-up, but not necessarily injury. So that being said, you might want to ignore my next several slides on posture because I still do believe it matters. And for those of you who have read Anatomy for Runners, you know that Jay is kind of playful, and he breaks it down to 3 big categories. Our lady in the middle shows what he calls the toilet bowl of doom posture. And I measured her to have about 13-degree forward lean. Now, this usually comes from weak glutes and core that leads to excessive forward lean. Now, with that lean, with every step she takes, she's about to fall forward on her face. So she really has to put her foot out in front of her to stop her. This is your biggest overstriders who can have a really high loading rate. We'll talk a little more about that later, and probably at a pretty big risk for injury. Now, she actually came to me for knee pain, which might not actually be associated with overstriding, but I've never really seen it hurt someone to work on decreasing overstriding or working on better posture in this position. So I would definitely think of this with a high loading rate as increased risk of bone stress injuries and also injuries higher up the chain. I still think it sends a shockwave force even to the hips and low back and pelvis, but really might cause injuries to multiple areas. This has also been shown to be about 6 to 8% less efficient than good posture. So again, not just fixing injuries, but if we can make someone 8% more efficient, that's pretty good. That'd be about 4% more efficient than the fancy Nike shoes can do. Then next we have probably what's more common, the backseat posture, often caused from tight hamstrings, or tight hip flexors and lower quarter cross syndrome, or as we call it in anatomy for runners, the female adolescent texting syndrome, although many males are affected from that syndrome as well. You see this with an inactive core, overarched back, anterior pelvic tilting, inactive glutes. This gentleman is actually, he's a weird example of it because he is actually frankly leaning backwards. It's not the more typical example, but I will show some of those. In this case, it's almost like the center of mass moves backwards from where the foot is landing. So anytime the foot is farther from the center of mass, we're going to get a higher loading rate. It's just for a different reason in this case. Definitely think of backseat posture with back pain because we're kind of clamping down on those facet joints back there, and upper chain injuries as well. Always think about this with someone with recurrent hamstring strains or hamstring tightness. And this has been shown to be about 3 to 4% less efficient. And I'll tell you these efficiency numbers. I heard them on a podcast with my buddy Jay, but he did them in a small non-published study. So take that for what it's worth, I guess. Now here's some more typical examples of what you're going to see with what I'd call backseat posture, that lower quarter cross syndrome posture of kind of a significant anterior pelvic tilting and increased arch in the low back. The lady on the left has chronic hamstring issues, and the lady on the right has a new anterior hip and thigh issue. Now, back to this gentleman who came in leaning backwards. He really wasn't injured at the time. He saw me give a presentation about gait analysis and wanted to come in. He's in his mid-60s. His complaint was that he was slowing down more than he thought he should. He was a very competitive runner. And although no injuries, he noted that the only place he ever felt sore when he ran was his quads. So I saw him late January. 2 weeks later, he came up to me at the Mardi Gras Mambo. I almost thought he was angry for a second, and then realized he was actually pretty ecstatic. He had actually hit or tied a PR at the 5K and the 10K mark, finished a race with the PR, and had no quad pain while he did it. And basically, if you measure these two lines, all he had really done at that time was make about a 5-degree change. He was pretty much straight up and down, but he felt like he was leaning forward because he was so used to leaning back. So again, does make me think that although our research has trouble proving it, I would not neglect posture. And then finally, what does fairly good posture look like? Well, we do want to have a fairly neutral spine, and we're going to have some slight anterior pelvic tilting, especially the faster we run, but we want to have about a 4 to 6 degree forward lean. The girl on the right is a Division I collegiate cross country and track runner. Girl on the left. The gentleman on the right is a nationally ranked ultra runner. So in case you think posture matters and you want to work on it, I would look at undoing some sitting damage, especially with our rounded thoracic spines nowadays. Again, not a lot of research. I did try to look into it and couldn't find a lot to support my point, so I might be wrong, so I'm going to point that out to you. This study, although not statistically significant, they did show that working on thoracic extension in addition to lumbar stabilization produced better changes in lordotic angle and oswestry disability index rather than just the stabilization alone. So if you think it's worth working on, you can pull out your manual therapy skills, start loosening up that thoracic spine so that it can rotate and extend so we're not just overarching the low back instead. I always like to educate my patients on things they can do for themselves, empower them in that biopsychosocial model, teach them some stretches they can do. And besides just mobilization, I always like to kind of strengthen things as well. And so our spines do need to be able to rotate when we run. And finding any exercises work on that probably be worth doing. But probably the single biggest cause that I see that relates to a lot of running injuries is hip extension. Everyone's usually focused on stretching their hamstring, but I think most people could stand to improve hip extension instead. So if I want someone to be able to get their leg behind them to push off, the person on the table right here is going to have trouble doing that. And if he's trying to run, he's going to have to really cheat that movement from somewhere else. So people want to run faster and run like an elite. They need elite level hip extension, right? Tends to be one of the biggest differences I see between recreational and high level runners. Pretty much all of our elite distance runners have pretty beautiful hip. And even in my quote unquote normal folks who are high level runners, we're seeing around 20 degrees of hip extension. Now, if we want to work on improving hip extension, I do still recommend stretching. I've moved away from stretching in general, but find most runners can benefit from getting that hip flexor a little bit looser. I Googled the internet and found this guy's blog where he claims to teach you the best way to stretch the hip flexor. And I said, great, I'm going to keep this example forever as a picture of how I don't want people to stretch their hip flexors. What's going on here? I see a pelvis that looks like it's fairly anteriorly tilted. I see a femur that looks like it's kind of in line with the lumbar spine there and thoracic spine right about here. And all he's really doing is crushing down on that thoracolumbar junction. He might begin a little hip flexor stretch, but if he's spending 30 to 60 seconds a day, thinking that he's working on hip extension, he's kind of teaching his brain to feel this position as hip extension. And then if he tries to run and use it, he's going to be falling into that backseat posture with overarched back. So instead, we put our runners in just a tall, half kneeling position. They can do this in a doorway so they can feel the arch in their low back there. You can see a little bit of daylight between the post and her back. And this is about the only time I'm going to have a runner do kind of a full posterior pelvic tilt, really kind of bracing that core, and ask her to squeeze the glute on that right leg there to help tilt that pelvis back more and bring the front of the pelvis up away and feel the stretch through the front of the thigh like that. And then they're going to hold that for at least 30 seconds. But the only thing research really shows with stretching is that the longer you hold it, the faster you see some results. Now, besides just stretching, since no one really likes to stretch, and although stretching does loosen muscles over time, there's just more and more research showing that eccentric exercise not only improves the length of muscle, but it also makes it stronger at the same time and adds strength to tendons as well. That's why we use it so much in rehab. So I'm kind of slowly moving away from even hip flexor stretching and trying to do more dynamic activity like this loaded eccentric hip extension. Actually got this off of Instagram and thought it looked great, and do like it for a lot of my runners. You can progress from doing it on a ball to doing it with the back foot on a slider, and then eventually you actually do it with the front foot on the slider. Now, I'm not trying to balance. I'm not really trying to work my left leg so much. I'm just really trying to kind of load up that right hip flexor as I slowly go into an extended position and then pull myself back forward with my front leg and arms. Once we've improved some of our ingredients of thoracic mobility and hip extension, we need to work on that neuromuscular control, as posture is something that's fairly deeply ingrained. So you can see here the girl on the left is standing in that backseat sort of posture. I'm going to do a vertical compression test on her, push straight down on her shoulders, and you're going to see that her low back folds like a chair. And then I'm going to have her put one hand on the belly, one hand on the chest, feel the weight in her feet, and just drop her chest forward until she feels like that weight is pretty equal on the forefoot and heels. We're going to pull the shoulders back a little bit. I didn't really fake this video. I pushed down really hard the second time, and you can see that she doesn't fold at all. And that's good posture, but it's something that they're going to have to repeat often throughout the day. And even when they run, we'll have them stop every few minutes, kind of reset their posture, and then take off running again. Of course, it if we have any core weakness, we need to kind of strengthen into that good posture with good position. And we'll talk a little more about planks later. But something else I really like that if you have the ability to do in your clinic would be carries, suitcase carries, farmer's carries, overhead carries to reinforce good posture. And part of the reason we want good posture is for core control and stability, which is really the ability to keep our spine in a stable, good position so that it can generate and transmit forces well. We have the saying that you can't fire a cannon from a canoe, so there's no point having strong glutes and strong legs if every time we push off we're kind of wobbling all over the place. So some of my favorite exercises for that as we start getting more and more into exercise, quadruped. Not always the hardest core exercise, but I think it's really good for kind of that neuromuscular control. And this is where, someone who's had some back issues, I think it's a really good exercise in addition to runners who need more core awareness. And it might be that they're only starting with lifting an arm. If they can handle that, we can do just a leg. Obviously, once they get that down, we can start alternating arms and legs. I really like this picture as her spine is not changing position. We'll certainly watch the person to make sure they're keeping that core tight, not letting the back arch. And if they're rolling their pelvis, I'll put a stick across their back as a little biofeedback. If they roll too much, that stick's going to fall off. Of course, this can be progressed to donkey kicks, fire hydrants, which I don't think I included. One of my favorites is what I call J-Dogs, named him after the guy I learned it from. And it's kind of like kicking back combined with the fire hydrant. We're going to kind of kick out and back around 30 to 45 degrees. And for a little extra glute med cramping, you can try to rotate your toes outward as well. And a donkey toes exercise where you're doing donkey kick, but you're keeping your both knees off the ground, alternating legs, good bit harder. Now, some hardcore, even the runners I know in Baton Rouge, varsity group, they're always doing plank challenges. Planks are great for static core endurance. Don't leave out side planks. We can work that lateral chain as well. Even the folks who plank all the time tend to avoid the side plank because it sucks, or they just suck at it and stand to improve from it. If they push their feet down, instead of just thinking about planking up, they can get a little bit of a glute med activation as well for full lateral chain. The only issue with planks is they're a static exercise, and running is not a very static sport. It's pretty much always dynamic. So once they can build up to 30 to 40 seconds of holding a plank, I want to start challenging them with movements. And there's a pretty wide variety here. You can let your imagination run wild. So we can just have a plank with a leg lift, Spider-Man planks, pulling that knee up and out to the side. Toe tap planks are probably one of my least favorite, foot out and back in before switching feet. Thread the needle side planks, thread the needle high plank here, and one of my most favorite running man side plank. This picture doesn't quite do it justice, as I'll take his hand off of his hip and have him kind of pretend like the top of half of his body is making a running motion while the bottom half holds a steady plank. So more keys to better mechanics. We've already talked about a few of these things, but we'll get into just a little bit more detail. We're going to talk a little more about loading rates. We spoke a lot about how to be able to get the leg behind you from a range of motion standpoint, but we need to talk about a movement standpoint, and then a little more on the strength necessary to control some of the forces of running. So what is this loading rate? So in a lab like at UVA or other high-tech gait labs, they have force plates embedded in the treadmill, or maybe a force plate on a runway. If you have a runner run and land on the force plate, they'll generate a graph that looks like this. Between 5 and 10 years ago, this was sort of the answer to everything in the world of running medicine. Saw some really great lectures from Irene Davis and others saying that we could link most running injuries to a high loading rate, which is basically the slope of this line as it goes up to this impact peak. And the thought was that if we can decrease not so much the height of that impact peak, but just the rate at which force hits the body, and smooth out that line towards the active peak, we would get rid of a lot of injuries. This still seems to hold true for bone stress injuries like tibial stress fractures and probably anything on that spectrum like the medial tibial stress syndrome, and also think about it with compartment syndrome. Honestly, I still think about it with injuries higher up the chain too, but new research says it might not be quite as important as we used to think. The same At the same time, I'll tell you, I never really saw someone get worse by working to improve this. Now, here's a runner who I believe would have a pretty high loading rate. I say I believe because this is a fairly regular treadmill and not a $120,000 treadmill with force plates embedded in it. But have no fear if you're in clinic without a $100,000 treadmill. There was an article in JOSBT, man, quite a few years ago now, showing that even with a camera phone, you could probably pick out a lot of the things that would indicate high loading rate. One of the things is vertical oscillation, which I don't really measure, but I could tell that this gentleman had a slow cadence, a lot of up and down motion. Certainly his foot inclination angle at initial contact. This was measured using OptiGate, but you could use software like Huddle as well. And I think in his foot, you can just eyeball that and know that that's hitting the ground greater than 10 degrees, which is correlated with high loading rates. And then I just look at how far the heel is from his center of motion. Really, I kind of just look at it in relation to the body. I don't believe it was in the article, but something else to note as well is that his knee is almost completely straight. So he's just sending a big shockwave up his body. I believe he came see me because he kept suffering from chronic shin splints, kind of like I did in high school. And we talked a lot about cadence and how to improve that, and I don't think I've seen him back, so hopefully it worked. Contrast his running style with my buddy Walker Higgins here, the ultra runner who's done Badwater and has won some other big races. How can he get away with racing 100 miles without too many injuries or shin splints versus the other guy who couldn't run more than a few miles? Maybe part of it is this loading rate. And if you freeze frame him, he lands with a midfoot strike. Just very briefly, I'm of the school of thought that it doesn't matter if it's a heel strike, forefoot strike, midfoot strike. What I care much more about is how close are you landing to your body. And you can see here that if we draw that line, that same line from the heel, Walker's kind of catching his chest and half of his face. And so we just know that he's landing a lot closer to his center of mass. And he has a nice bent knee to help absorb some of the impact landing. Now in Gait Lab, they talk about braking forces, and I kind of use the play on words of braking and braking forces, again, explaining to your runner how these things not only help injury, but can help improve performance. The further out in front of you that you land, the more we have a force vector that's also trying to push you backwards, basically breaking your forward momentum and slowing you down with every step, which then you have to work harder to overcome that. Versus if you look at Walker, it's a much more efficient gait there. Nice green arrow. He's landing really close, so he's going to have less braking forces. Every single runner is going to land in front of them no matter what, but the closer they can land, the less of some of these negative impact forces and braking forces that they have to deal with. Now, our runner who had that higher loading rate, I think part of it was his slow cadence. You may have heard about cadence. Unfortunately, you still hear people, most don't even know about cadence, and ones who do still might have the magical 180 number stuck in their head, which is kind of a misreading of that data. Really, I kind of put the low end around 170, 172. It certainly can be height dependent and it can be speed dependent. So a tall person jogging very slow might be okay in the 160s versus a shorter person might still need to be in 170. But certainly anyone who's running at a fast pace or racing can usually benefit from increasing cadence. There's been a good bit of research on this, and last weekend I sat through a lecture that should have been in Virginia, but instead was in my living room, kind of like you're sitting through now. And Christopher Johnson, great PT out in Zareen PT, I believe in Seattle, talked a lot about cadence and how much research there is showing multiple benefits to improving cadence by 5 to 10%. If you start improving over 10%, you'll tend to kind of reduce economy, but I think 5 to 10% is usually enough for most folks. And there's at least one study showing that it really helps reduce patellofemoral joint forces, but I'd keep it in mind for shin splints, stress reactions, lots of issues. So how to fix it? Probably the best way if you have a treadmill in the clinic is have the runner practice a few times a week at bumping up. Measure them where they are, and if you find they're at 160, maybe just bump them to 170. Eventually, you might be able to get them to around 175, having them run with a metronome. There's also a lot of different running apps that they can look into, and there's apps that even play music at the cadence that you want. It's probably easier to get the right cadence using a metronome, but you probably want to blow your brains out after a few minutes of listening to a metronome while trying to run, and so the music might not work as fast, but might be a little more pleasant. So now we've learned how to have good posture. We've improved our hip extension with either stretching or eccentric exercise or both, but we need to strengthen into that motion now that we have it, right? So bridges are one of my favorite exercises for runners. I'll start this playing and I'll just kind of talk through it maybe a few times. One of the things I learned at UVA was that a lot of our PT gurus did the same exercises that other PTs were doing out in the wild, yet it seemed to work better. And I think part of it was that we had a very large focus on cueing. So both with anyone with back pain and certainly any of my runners, I find that hook lying position. I'll start off by finding their anterior superior iliac spine, slide my fingers up about 1 inch and then in about 1 inch. So I'm not over their rectus, and I have them brace their spine. I put one hand on the low back, feeling that they're not just going into posterior pelvic tilt, which many of them have been taught. I really want them to focus instead on spine neutral core bracing. I also have them put their heels close enough that they could touch it with their hands. As the heels get closer to the butt, it forces them to use the glute max more than cheating through the hamstrings. And then they drive down through the heels and actually squeeze the glutes before they ever lift up. So bridging is not going to build a ton of strength. You're not moving that much weight, but I think it's good to do for a few weeks to practice that sequence of brace the core, squeeze the glutes, drive through the hip. Once they can handle that, we move to bridge marching, concentrating on not overly rotating side to side. Once they can handle, and let me give you some numbers. So bridging, we might do 3 sets of 10 for a lower level runner, 3 sets of 20 for a higher level runner. Bridge marching around 3 sets of 12 to 20. Move up to some single leg bridging. We're going to do all on one side, then all on the other side, 3 sets of 10 to 15. Bridging on the ball, now we're going to very much on purpose get the hamstrings involved, and the ball, certainly with the arms up like this, would increase the need for lateral and rotational stability. Single leg curl, pretty tough. She pulls it off on both legs, and that's why she's going to look at the camera with a big smile, because I'm not sure she was totally convinced she could do this before she did it. So good job, Rochelle. So once we've progressed bridging so that a runner understands how to activate their glutes and extend at the hip while maintaining spine neutral, it's time to move beyond the mat and further strengthen the glutes and advance to a standing exercise. I like to start with chair of death squats. If you took a group of 10 runners, you'll probably see 7 or 8 of them squat in a very quad dominant pattern with their knees shooting forward, upper body very upright, very little use of the hip, but significant overload of the patellofemoral joint. The chair of death squat here is just a way to kind of cue them into using the glutes more. We put the toes right under a chair or bench and have them try to sit back more so that their knees don't go forward and touch the chair. She's using the stick on her spine here to help maintain spine neutral. Once she gets the hang of keeping the spine neutral, we can put it down so she can put a little more weight forward and squat a little bit deeper while still using a very deadlift or glute dominant squatting pattern. Then we can progress this to lunges. Again, our big cues are going to be not really letting the knee shoot out way past the toes, and also really avoiding any dynamic knee valgus, trying to keep that knee pointing straight ahead. Then we move into single leg deadlifting. I usually start this with double leg deadlifting and just working on getting that hip hinging sort of pattern. But obviously with a single leg, we're going to work the whole posterior chain a little bit harder. It involves balance and foot control as well. While the controlled movements of squatting and lunging and even single leg deadlifting are great and can build some strength, we got to keep in mind that the sport of running actually demands a lot of power. You have to be able to put strength into the ground quickly. So once we've developed some strength and can use our glutes, something you could do in clinic at probably most locations is a little bit of plyometrics. The other way to build power is heavy weightlifting, but there's not that many clinics around that have squat racks. I love the ones that do. Hopefully more of them get it, but these exercises are stuff pretty much everyone could do in clinic. So we'll start with plyo mountain climbers or explosive mountain climbers rather than butt bouncing up in the air and kind of jogging for a cardio workout. We're really focused on explosive hip extension. Move to box jumps. We teach something called a ninja jump where she's going to try to land nice and quiet and softly. You can progress that to a depth jump, getting hopping down, absorbing force, and getting back off the ground quickly. And then a really tough one is rebound jumping. Now, one of the things with plyometrics is that these should be done in pretty small dosages so we don't lose our form and technique. So, sets of 10 to 15 seconds are fine. Lateral jumps to work some of that lateral strength and stability. Maybe instead of a foam roller, you could start at just hopping over a TheraBand laid on the ground for safety. Now, if you have a heavy power band or a monster band, you might not necessarily need heavy weights to be able to work your patient pretty good. So here I'm demonstrating banded ski jump squat, kneeling hip thrust, or kneeling deadlift, whatever you want to call it. These band drive-throughs are a little tricky. It takes everyone a while to get the hang of it. Not sure I'm the best model for this, but it is one of my favorite exercises to work on that hip drive and using that glute max quickly, not just slowly strengthening it. We got to teach it to fire quickly so that can help us better when we're running. I'll let these play through one more time. Make sure our presentation goes over 50 minutes here as well. On this band drive through, the leg that starts in front and finishes in back, that band is only around my left leg here. And I'm trying to get that leg behind me, even though it's not really happening. Certainly thinking about it as I do it. All right, here's a funny little drill. So in the world of track and field, they have A skips and B skips, something that we call C skips, but you will probably never find if you try to Google it. So I'm going to demonstrate it here, and feel free to laugh at me. First, we're going to start with C slides, and then we're going to move up to C skips. So again, thinking through this, we need to have a hip extension range of motion. We got to have a strong glute that we can tap into quickly. But just because we do those two things, they might never show up in our running if we're not used to running with them. So this is a drill to kind of help the brain start putting these pieces together for our good recipe to go with our improved ingredients. So on the C slide, I'm going to put pretty much 95% of my weight on my left leg, toes just barely touching the ground on the right leg, get the opposite arm swing involved. I'm trying to pop that leg back. I don't want to pick it up in the air. I want to actually drag it back. And then once they get the hang of that, we can turn it into sort of this weird running man skipping drill that my class has been doing for a year or two, and they complain about it every single time we do it, but they've all obtained PRs and have had less injuries, so I think there might be some point to all of this stuff. This is one of my favorite pictures out of anatomy for runners, and we have to remember that there's a lot of forces acting on a runner when they run. The biggest one is gravity trying to squish us down with about 2.5 to 3 times body weight, but we also have forces coming at us side to side, usually about 20% body weight. We have forces coming front to back, up to 50% body weight. We've talked a lot about front to back exercise so far. And then there's also rotational forces, the free moment arm that we have to control as well. And, some people say that running is not a strength sport. It's a low load applied multiple times. But again, if we start thinking about 2.5 times body weight, this 130-pound female is actually seeing a lot of force. So running can actually be looked at as a high load that is applied multiple times, right? So she goes from smiling versus less of a smile when she's trying to pick up 2.5 times her body weight. And again, this happens to us at the active peak. So moving from the loading rate and the impact peak, definitely some truth that a lot of the injuries probably happen at the active peak when we're trying to control those biggest forces. So the question is, do we look like this gentleman here who, although he has his head turned, he's scouting out his opponent, right? But otherwise he's got his shoulders stacked well over his hips look nice and level, spine nice and straight, hips over the knee, knees over the foot. Looks like he's leaning, but you can tell he's coming around a turn. Or does our runner look more like his competition here, right? Whose shoulders are a little less level, looks like we got a hip drop, a little spine curve, a knee that's, pulling on its IT band and ACL for dear life, and an ankle and foot doing whatever it's doing down there. So let's try to get our runners to look a little more like a Usain Bolt, at least in terms of, their ability to control some of these forces. So real life example of this, this high school girl came to me. She had been a cross-country runner, loves running, had actually done pretty well until about 1 or 2 weeks into track season a couple years ago, developed severe right knee pain and had to stop running. Saw several different doctors, if I remember right, had tried therapy, I think, at 2 places. Saw Dr. Jeremy Burnham when he was still at Bone and Joint, who sent her to me when I was still at Morrow. And he had found that she had pretty significant anteroverted hips, and really the only thing he could offer her would be, an osteotomy, a derotational osteotomy, I think they call it, but I'm sure not a surgeon. And I'm really looking at this girl, she stands with her hips in neutral and her feet in neutral. Her knees are staring right at each other. They're pretty cross-eyed, and honestly, I wasn't sure I'd be able to help her. But before we took this running video, I took a walking video, and with OptiGait, I could measure adduction. We can't really measure rotation, but we know it's a coupled motion. And she would go into about 10 degrees of adduction walking, but that increased to 16 degrees when she was running. And I said, maybe if we can cut down on that dynamic component of it, that even though anatomically she's a mess, if we could fix the dynamics, maybe she could run again. And after about 2 months of good physical therapy, as well as actually going through our power running class, she was able to get through, I think, 1 or 2 full cross-country seasons now, as well as a track season before, unfortunately, her senior year track season was cut short. So a success story just by working there. Another high school runner, this guy was really high ranking in pretty big school division, was doing well during cross-country season, but having a little bit of left knee pain. Watching him run, big picture, what do we see? Maybe a little bit of left head tilt. I feel like my camera's a little off here, and that's throwing some things off. But I would say ever so slightly, he's got a leftward lean, and sometimes it looks like that left arm's a little wider than the right, but I might be making that up. And then I see just a little wiggle in his knee when he lands. One of my favorite drills to assess a runner is a single leg squat. Some people do it more as a single leg step down. I think either one is okay. I look at basically at least 6 points. 3 points are related to hip abduction strength. So he's leaning over quite a bit to the left, the same as we see running. So minus a point for that. I'm watching his knee kind of point inward of his big toe multiple times, minus a point for that. And or if they get a hip drop, we'll minus a point, but he's not really doing that. Then I also look at 3 points for balance. If his hands have to come off of his hips, minus a point. If his other foot touches down, minus a point. And if he loses first ray contact like he just did, let's see when he does that again. Almost. So I want to be able to make sure they can kind of keep that big toe on the ground for support. So, basically a little bit of balance with foot control, which controls the knee to some degree, but more issues up at the hip. So evidence for hip and core strengthening, really lazy slide right here instead of digging too much into research. Let's just face and admit the fact that there is a ton of research out there that has shown increased risk of running injuries and sports injuries in general whenever we measure weakness with the hip abduction, and a lot of these have looked at hip external rotation as well, not to mention just core strength in general. And there's a lot of research showing that if you improve on those weaknesses, we fix injuries and cut down on them. So now to clamshells. I'll start this plan and give a little dissertation. Two of my biggest PT mentors at UVA, one hated clamshells with a passion, said it was not functional in the least bit and no one should ever do them again. My bigger mentor, Jay, from the Gospel According to Jay, says, hey, there's a place for them. There are good activation exercises. For activation, we want to be able to do lots of repetitions, and we want to do lots of repetitions. It needs to be kind of a light, easy exercise. Again, talking about cueing, I think that's one of the reasons that it maybe worked a little better at UVA is that we would even brace our core in that side lying position. You could see that in all of these, I have my head resting on my fist and not propped up in the air because I want to keep that spine from head to tail as straight as possible, brace core, and in the clamshell position, the whole time we're doing clamshells, we want to keep both glutes squeezed as well. So if someone has no idea how to kind of activate their glute med, I'm going to start them with clamshells and we're going to do high volume, 3 sets of 30 repetitions for a couple weeks, and then we're going to move on to something harder like side lying leg lifts. But if I want to do high volume, the last thing I'm going to worry about is putting a TheraBand on, because if you're putting a TheraBand to increase strength, why don't you just do a better exercise instead, like side lying leg lifts or the 7-way hips that I just showed you. But none of these side-lying mat-based things are all that functional, right? So the way we use a muscle is kind of how our brain learns to use it. I always want to kind of get my runners upright, doing more functional exercises. The hip hike tends to be kind of neglected. Every now and then I see runners who do it, but most of them, it's a really simple exercise that they can do anywhere. Now I get a chance to work on posture. I get a chance to work on balance. We're not going to get into toe yoga during this presentation, but I have my runners combine it with toe yoga as well, and we're actually feeling the whole purpose of that gluteus medius muscle to be able to control that pelvis and keep level. Good progression from that would be what I call the Ferber exercises, because I learned these from Reed Ferber. He talked about this at UVA Running Medicine conference several years ago, which, by the way, I suggest all of you go to if you really want to be top-notch when it comes to working with runners. I couldn't find published report. I kind of think he was giving us a presentation on something that wasn't published yet, and I'm not sure it ever got published, but I did find this abstract from 2012 that seems to talk about this. And it was a combination of 3 exercises. I'll show you the other one next, but band pulling straight out to the side as much as possible. I want to use balance and tight core and good posture. Band pulling out and back 45 degrees. I like to throw in a little bit of external rotation for bonus points, as we know that's associated with decreasing injury risk and fixing injuries. And then I'm going to skip ahead and show you probably one of the single hardest exercises I find for runners is standing clamshells, which don't bear a lot of resemblance to the lying clamshell. So I'm going to stand on one leg, get that knee into kind of a quarter squat. I'm trying to pull both knees apart at the same time. I think if I were actually coaching myself, I'd say, oh, your knee just dipped in a little further than I wanted to. Either tighten up that right glute or don't try to pull so far to impress the camera. I'm going to switch sides and do it here. So in the Ferber exercises, in that experiment, they did 3 sets of 10 repetitions daily for 6 weeks. After 3 weeks, people with IT band pain were able to get back to running with very little pain. Whenever repetition number 9 and 10 got easy, they would give them a harder TheraBand. If your runners have a limited supply of TheraBands, you might start with 8 reps, progress to 12 reps, give them a harder TheraBand, go through the same progression. But one of the keys there was that they were doing something almost every single day. And of course, if they can do standing clamshells, I probably wouldn't do that every day, but a few times a week, really good exercise to work that whole lateral chain and rotational chain. Now here on the left side, standing hip external rotation with resistance. This was the other one of the Ferber exercises. This one's really confusing for patients in clinic. I always make them demonstrate this. They're just holding a TheraBand against their hip to put a little resistance into the hip, but she's holding on the left side there, but it's the right hip that's doing the work. And sometimes I find the cue of telling them, think about turning your stance foot outward really helps. Because what we're trying to work is kind of a pure hip external rotation motion. And then our right side here, we have this rotisserie chicken exercise. One of my favorites, you would definitely put this after single leg bridging. Once they learn to single leg bridge without rotating the purpose, now we're going to rotate the pelvis on purpose, but with good control. Now, besides hip rotation, we need to have a lot of rotation through the spine and pelvis as we're running. So the Swiss ball tuck twist is a good one as long as you don't go too far, like right there, and have to stabilize yourself. Of course, it requires a little bit of upper body strength, but trying to work on rotating through the spine and pelvis and controlling it so I don't fall off the ball here. Fun, challenging exercise for a lot of runners. So a little recap, if your runner wants to know what it takes to have, maximum performance, well, they need to be born with a pretty good anatomy and structure, so pick their parents wisely, as they say. They need to be really smart about their training, which we really didn't get into. Sometimes I talk about that in terms of dosage. It's certainly something to think about if runners making more than a 10% weekly jump too often, likely to lead to injury. And then they need to have good mechanics. They got to have the right range of motion to get the leg behind them, no more, no less. Got to be able to control that posture and core control and have good stability from kind of the foot up and the core down. And even our distance runners need to have some power and a higher rate of force development. Sure, they need to have good cardio and lung capacity, but the runner who can kind of put the most force into the ground the quickest is going to run the fastest. Hopefully it gave you some ways to think about doing that. So my take-home points here, be an enabler for your runner. Help them maintain fitness while they're rehabbing injuries. So anything you can get them doing that's going to keep that cardio up, like pool running or elliptical or Alter G if you have it, is going to help them be a little more compliant and give them some of that cardio fix that they need. Get buy-in by explaining how good therapy can help their injuries and improve performance, and then make sure you actually do good therapy. Watch them run when you can. Put them on the treadmill, watch them run outside if you need to, and look at the big picture. Don't get hung up just on the feet. Look at posture, cadence. Do you think they're overstriding? Do you see a lot of lateral instability? Are they moving side to side? Do they have a wide arm swing? Is that knee crashing inward? Break it down into small tests like single leg squat test. Then try to meet them where they are and progress them to where they need to be. If they've been doing clamshells for 2 months, another 2 months of clamshells probably won't help. Move them up the ladder. Find the hardest exercise that they can do well and start them there. If they have no idea how to use a muscle or turn something on, it's good to start with low intensity but high volume for motor activation. But really, before we get back to running, we need to get up to some higher intensity and lower volume exercises for strength and power. These will be more applicable. A couple little things I didn't dig into too much, but just to review or to tell you, I would focus on control certainly first. No point to adding volume or intensity to dysfunctional movement. Whenever possible, we want to get the standing exercises, get off the mat. And if it's an exercise that can be progressed to single leg, even better than double leg, as running is pretty much a single leg sport by definition. Improving mechanics might trump all, but there's a lot of things that go into changing those mechanics, certainly not the least of which is strengthening. If you're going to do nothing else, at least focus on strengthening, as the vast majority of research shows that it's the best way to treat and prevent running injuries besides being smart about training. And don't be afraid to progress that strengthening to a higher level, as running is a pretty heavy strength sport. I think this works better than just focusing on mobilization, manual therapy, and stretching, but certainly those might have their place if we have a range of motion issue. Sometimes you can throw dry needling in that as well. I've just seen a few too many runners who seem to think that dry needling will be the one and only fix of their problem. I kind of think of it as a pharmaceutical that a therapist can offer. It's going to make them feel better for a little while, but it doesn't usually do much to fix the injury, but certainly it's going to do more than passive modalities like ultrasound, heat, and e-stim. So you can find me a bunch of different ways. You got my email here for Oshner, my personal Gmail. I'm on the Facebook and the Instagram, and we're starting to get on YouTube at Power Running / Dr. Casey Hill, I think. Don't have a lot of stuff on there yet, but we'll be building that up. I'll work at the Grow for Oshner. If we're still here in a few months when this zombie apocalypse is over. And there is the number to clinic. Unfortunately, can't really take questions in this setting, but please feel free to email me, Facebook message me, whatever you have questions or comments on. Hope you found this helpful and not way too boring. It was kind of boring to sit here and talk to myself, but hopefully you got something out of it. And I really appreciate the opportunity to talk to you guys and would love to do it again sometime. Thank you.